So let's start with osteoarthritis today, also OA. It's one of the most common arthropathies causing pain and instability. It is characterized by the progressive loss of articular cartilage and remodeling of the underlying bone or the bone, whichever bone is affected. It also has an incidence which increases with age. It is more common in females as compared to males, especially in the patients as they grow older or above the 50 years mark. The incidence rate is joint specific. It is more common in knees, then hips, and then in the joints of the hand. Considering the pathophysiology of osteoarthritis, the chronic mechanical stress on the joints and age-related decrease in the proteoglycans can cause cartilage to lose its elasticity and become friable, and this can lead to degeneration and inflammation of the cartilage, joint space narrowing, and the thickening and sclerosing of the subchondral bone. The risk factors of osteoarthritis can be divided into modifiable risk factors such as obesity, excessive joint overuse, or non-modifiable risk factors such as age. More than 50 or 55 years of age are more prone to having osteoarthritis. Female are more prone to having osteoarthritis, and if there is a running history in the family. Then if there is a history of joint injury which can lead to osteoarthritis, which makes it prone to osteoarthritis, asymmetrical joint stress, hemophilic hemarthrosis, and deposition diseases that may stiffen the cartilage. All these can be the non-modifiable risk factors. Now let's classify osteoarthritis. Classification of osteoarthritis is either idiopathic osteoarthritis, there is no identifiable cause, and it can be localized or it can be generalized. There can be genetic factors involved here. The other classification is secondary osteoarthritis, which is where we suspect in patients with atypical joint involvement or an earlier onset. The conditions that may lead to secondary osteoarthritis may be hemochromatosis, Wilson's disease, diabetes, avascular necrosis, congenital disorders of the joint, joint trauma, alkaptonuria, Ehlers-Danlos syndrome. Now you can pause here the video and read this slide properly. The clinical presentation mostly presents in the common joints, that is your small joints of the hands and feet, the hip joint and the knee joint. The patient will most commonly present with pain with joint stiffness. Now this can be reduced with rest, but it increases with activity. Pain is present in both complete flexion and extension. The joint may have a restricted range of movement and there might be a sound of crepitus. Patients generally feel morning stiffness in the joints involved, and there may be an involvement of asymmetrical joints, which we have already seen happens in the secondary osteoarthritis. In the late stage disease, there will be a constant pain, including in the night, and a severely restricted range of movement. In diagnosing, there might be joint specific findings. Heberden's nodes. These nodes are present in distal and interphalangeal joints. These are painful nodular thickenings present in the distal interphalangeal joints. In the proximal interphalangeal joints, these nodes are known as Bouchard nodes. Then you have rhizarthrosis involving the first carpometacarpal joint between the trapezoid and the first metacarpal bone. Then you have hallux rigidus. First metatarsophalangeal joint is involved between the first metatarsal and the first proximal phalanx. It is characterized by the hypertrophy of the sesamoid bone in the foot. Now let's discuss individual joints. So begin with hip osteoarthritis. Of course, it will present in pain in the groin region just above the greater trochanter. Now there will be an increased contracture in the flexor, external rotation and adduction position, leading to an antalgic gait. What is an antalgic gait? An antalgic gait is an abnormal gait which is produced due to pain. Now here the stance phase of the walking cycle is shortened in comparison to the swing phase. To understand this, you need to go and read a little bit about gait cycle to know about the swing phase and the stance phase. Alright, next you have the early signs. Early signs are limited and painful internal rotation of the hip joint. We do a Thomas test to test out the movement. Generally what is done is, the test is for hip flexion contracture. The patient is asked to lie down in a supine position and the examiner will passively flex the hip joint that is opposite to the affected side to a maximum to compensate for the lumbar lordosis. And a positive Thomas test is interpreted if the flexion contracture is present. The ipsilateral leg will simultaneously flex independently as a reflex. Now let's come to knee osteoarthritis. Of course, there is pain and swelling with which increases on activity. In case of patellofemoral osteoarthritis, positive patellar grind test can be performed and there will be pain on the movement of the patella. Lastly, the cartilage damage usually begins medially and may lead to genu varum, or that is which is known as bowing of legs. Diagnosis is mostly based on clinical examination. It's a primarily clinical diagnosis. You will also do routine blood tests and your diagnosis will be confirmed by performing radiology or x-rays. There are classical radiological features that you might see in the x-ray are loss of joint space, osteophytes presence of subchondral cysts and subchondral sclerosis. Once you have diagnosed the patient with osteoarthritis, the management is generally done conservatively. Patient education is of prime importance. They should be told about the progression of the disease and joint. Strengthening exercises should be given, prescribed to this patient. They should be advised to lose weight if they are overweight. Local heat or ice packs can help. Joint supports are provided and definitely physiotherapy improves the outcome of the disease. NSAIDs or intra-articular steroid injections are used to subside the pain. Surgical interventions may be required in some cases when you can perform an osteotomy, arthrodesis, that is joint fusion, and arthroplasty. Let us summarize the key points now. Osteoarthritis is characterized by progressive loss of articular cartilage and remodeling of the underlying bone. Risk factors, of course, involve the obesity, advancing age, more common in females, and overused joints. Clinical features involve pain and stiffness in the joints, worsening with activity and relieved by rest. It's purely or primarily a clinical diagnosis confirmed by radiological investigations, and the management is mostly based on conservative treatment. However, sometimes surgical intervention may be required. I hope this lecture has given you a concise idea of what is osteoarthritis. Now, if you like the topic, if you like the lecture, go ahead, like it and share and subscribe. And also you can follow us on a podcast which is available on Spotify and Google Podcasts known as Clinical Musculoskeletal Anatomy, and the link for that is given in the description. So go ahead and follow that also.